Welcome to this presentation on acute hepatic failure, key clinical facts. I am Dr. Emorike, your host. In this session, we explore the core aspects of acute hepatic failure, including its clinical presentation, investigations, and management. So, stay focused and take notes. If you have not subscribed to our channel, kindly do so. Hit the notification bell and share with colleagues and fellow medical students so you never miss a high-impact clinical lecture in this channel. This is ClinMed Compass, your path to medical excellence. Let us begin with a pre-test quiz to assess your baseline understanding. Question 1. A patient diagnosed with acute hepatic failure has an INRO of 7.2, grade 3 hepatic encephalopathy, and creatinine 3.8 milligrams per deciliter. What is the next step in management? Question 2. Which of these is most associated with hyperacute acute liver failure? Wilson's disease, acetaminophen toxicity, hepatitis C, Buchari syndrome. Question 3. What is the most common cause of acute liver failure in developing countries? At the end of the lecture, you should be able to provide answers to this pre-test quiz. According to the American Association for the Study of Liver Disease, acute liver failure is defined as a sudden and rapid deterioration in liver function. It is characterized by abnormal liver function tests, coagulopathy, evidenced by an international normalized ratio INRO of greater than 1.5, and the presence of hepatic encephalopathy. Crucially, this occurs within 26 weeks of the onset of illness in a patient without prior known liver disease. It is important to state that you talk about acute hepatic failure in a patient without a pre-existing liver disease. The interval between the onset of jaundice and encephalopathy is critical as it determines classification. As previously stated, in acute liver failure, encephalopathy occurs within 26 weeks of the onset of symptoms. It is said to be fulminant if encephalopathy occurs within 8 weeks, and subfulminant if it occurs between 8 to 26 weeks of the onset of symptoms. Acute liver injury is defined as liver damage with international normalized ratio of greater than 1.5. But this time around, there is no encephalopathy. You need to understand that acute liver injury always precedes acute hepatic failure. Acute hepatic failure has high mortality rate without prompt supportive care or liver transplants. In patients with pre-existing liver disease such as cirrhosis, the appropriate diagnosis is acute on chronic liver failure, which is distinct from acute liver failure that we are discussing today. It is important to note that acute liver failure has replaced other and less specific terms like fulminant hepatic failure and acute hepatic necrosis in modern hepatology literature. Briefly on the epidemiology, the incidence of acute liver failure is estimated at 2 to 6 cases per million per year in Western populations. In developed countries, paracetamol overdose accounts for nearly 50% of cases of acute hepatic failure. In contrast, viral hepatitis, particularly A and B, is the predominant cause in developing countries. This condition shows a bimodal distribution. Young adults are often affected by drug-induced acute liver failure, while older adults may develop idiosyncratic drug-induced liver injury. The O-grade classification of acute liver failure is based on the duration between the onset of jaundice and encephalopathy. This classification helps to guide prognosis and treatment decisions. It is classified as hyperacute, acute, and subacute. It is hyperacute if the time from jaundice to encephalopathy is less than 7 days. It is acute if it is between 8 to 28 days, and subacute from 29 days to about 12 weeks. It is important to note that the faster the onset of encephalopathy, as in hyperacute and acute, the faster the development of cerebral edema. Any significant liver insult can lead to acute liver failure. Globally, the most common cause remains acute viral hepatitis, which is also the most common cause in developing countries. In developed countries like UK and USA, acetaminophen toxicity is the leading cause. Other causes may include autoimmune hepatitis, Wilson's disease, and drug-induced liver injury, as we'll find out in the next slide. This slide depicts the causes of acute hepatic failure from infectious cause, drugs, toxins, autoimmune, down to metabolic, pregnancy-related, and idiopathic. Infectious causes include the hepatitis A, B, C, D, and E. However, it's less common with hepatitis C virus. Herpes simplex, cytomegalovirus, yellow fever, leptospirosis are all implicated. Drugs like paracetamol, toxicity, methyldopa, anti-TB medications, anti-seizure medications like sodium valproate, phenytoin, even halothane, they've been implicated. Toxins and poisoning. Mushroom poisoning, the Amanita phalloides, and poisoning with carbon tetrachloride. Even herbal remedies fall into this group. It could be autoimmune or cholestatic. Autoimmune hepatitis, then primary biliary cholangitis and primary sclerosing cholangitis are implicated. But Chiari syndrome, veno-occlusive diseases, ischemic hepatitis, which is the shock liver, are vascular causes of acute hepatic failure. Wilson's disease, hemochromatosis, alpha antitrypsin-1 deficiency, all have been implicated. Pregnancy-related, as in acute fatty liver of pregnancy and the HEP syndrome, which is hemolysis, elevated liver enzymes, and low platelets. Other causes could be alcohol-related liver disease, non-alcohol fatty liver disease, and hepatic malignancies, including metastasis. It could be idiopathic in cryptogenic or non-A to E viral hepatitis, and this accounts for 10% of the causes of acute hepatic failure. Briefly on the mechanisms of liver injury. These include direct hepatotoxicity, as in paracetamol overdose, which leads to the accumulation of N-acetyl-P-benzoquinoimine and mitochondrial injury eventually. It could be immune-mediated injury, as seen in viral and autoimmune hepatitis. Cytokine-mediated hepatocyte toxicity and necrosis involving TNF-alpha and Fas ligand. These culminate in systemic inflammation and multiple organ dysfunction syndrome. These are the basic mechanisms of liver injury: direct hepatotoxicity, immune-mediated injury, and apoptosis and necrosis. An acute liver insult leads to a massive hepatocellular necrosis, which leads to a sudden and severe hepatocyte loss. This severely impairs the metabolic, synthetic, and detoxification capabilities of the liver and eventually manifests clinically as acute liver failure. So what are the major consequences of an acute liver injury? The first is the failure of detoxification, which leads to accumulation of toxins, especially ammonia, leading to hepatic encephalopathy and cerebral edema. Secondly, synthetic dysfunction. This causes decreased clotting factors, which leads to coagulopathy and bleeding, and reduced albumin production, leading to edema and ascites. Third, impaired glucose metabolism. which results in decreased gluconeogenesis and eventually hypoglycemia. The fourth consequence include renal hypoperfusion and vaso dysregulation, leading to splanchnic vasodilation and hepatorenal syndrome. Another major consequence is immune dysregulation. This leads to impaired neutrophil and macrophage function, increasing the risk of sepsis and multi-organ failure. Notably, cerebral edema and multi-organ failure remain leading causes of mortality in acute hepatic failure. Clinical features and evaluation. When evaluating a patient with suspected acute liver failure, ensure you take a detailed history. The symptoms usually progress rapidly, often within days to weeks. Ask about the use of prescription or over-the-counter medications or even herbal medications. Ask about alcohol intake or intravenous drug use. Recent travels, particularly to areas endemic for viral hepatitis. Ask about signs of viral prodrome such as fatigue, malaise, nausea, vomiting, and right upper quadrant abdominal pain or discomfort. This background helps narrow down the etiology and guide further testing. Other features include jaundice, which may be absent in early paracetamol-induced acute liver failure, fetal hepaticus, which suggests hepatic encephalopathy, ascites, and peripheral edema are late findings. Sudden onset ascites may indicate Budd-Chiari syndrome. Hepatomegaly is seen in early disease, but the liver may shrink due to massive necrosis. Splenomegaly is rare in acute presentation. Neurologic features include encephalopathy, ranging from confusion to coma. Symptoms like poor alertness, irritability, restlessness, aggression, drowsiness, and then coma. They may have hysterexis and constructional apraxia, cerebral edema. Look out for bradycardia, hypertension, hyperventilation, seizures, and papilledema. Coagulopathy is another feature. Patients may present with easy bruising and bleeding. Other features include hypotension, hypoglycemia, renal failure, and even sepsis. Now, we take a look at the grading of hepatic encephalopathy. Hepatic encephalopathy is graded using the West Haven criteria. It is graded from 1 to 4. Taking into consideration may include mental status of the patient, presence of hysterexis or not, and the EEG findings. Grade 1, mild confusion, poor concentration, such as a trivial lack of awareness. They may have euphoria or anxiety with shortened attention span. In this grade, they have a disordered sleep pattern. There may be or may not be hysterexis, and the EEG is usually normal. In grade 2, they have moderate confusion, they are lethargic, they are disoriented to time, and they also have subtle personality changes. These patients are drowsy but easily rousable. They definitely have hysterexis and the EEG is abnormal. In grade 3, they have marked confusion, incoherent speeches, gross disorientation, and they may be stuporous. Presence of hysterexis and the EEG is abnormal. While in grade 4, they have coma, which is initially responsive to pain, but later unresponsive. In this grade, there is no hysterexis and the EEG is abnormal. These grades guide decisions on airway protection and ICU care. In evaluating acute liver failure, consider important differentials such as infection-related encephalopathy, CNS infections like meningitis, metabolic disturbances, drug and toxin-related encephalopathies, stroke, or other mass lesions. Complications. Acute liver failure leads to multiple severe complications such as encephalopathy and cerebral edema, renal failure, often oliguric, and due to hepatorenal syndrome, coagulopathy with or without disseminated intravascular coagulation, hypoglycemia due to impaired gluconeogenesis, severe metabolic acidosis, infections and sepsis, hypotension and circulatory collapse, ultimately multi-organ failure. Investigations. Initial investigations include liver function tests. Alanine transaminase and aspartate transaminase are markedly elevated, often greater than 1,000 international units per liter in paracetamol toxicity. Bilirubin is often elevated in viral causes. Albumin may remain normal unless the cause is prolonged. Coagulation panel. An elevated INRO is the most important prognostic marker. A low factor V level also indicates impaired liver function. Electrolyte abnormalities like hyponatremia and hypokalemia are common. Further investigations. The blood glucose should be checked frequently due to the risk of hypoglycemia. Complete blood count may show leukocytosis or pancytopenia. Arterial blood gases may show metabolic acidosis. Serum ammonia is typically elevated. Toxicology screening is essential to assess for drugs like acetaminophen or other toxins. Check for alpha-1 antitrypsin levels if considering rare metabolic causes like alpha-1 antitrypsin deficiency. Screen for viral etiologies. For hepatitis B surface antigen and IgM anti-HBC. For hepatitis A, IgM anti-HAV. Consider anti-HEV and anti-HCV. Also screen for other viruses like cytomegalovirus, herpes simplex, and Epstein-Barr viruses. If Wilson's disease is suspected, order for serum ceruloplasmin, serum copper, and urinary copper. Perform a slit lamp examination for Kaiser-Fleischer rings. To assess autoimmune hepatitis, check for anti-nuclear antibody, anti-smooth muscle antibody, the liver kidney microsoma antibody, and soluble liver antigen. An EEG may be useful for grading the severity of encephalopathy and excluding non-convulsive seizures. Imaging is essential to rule out obstructive or vascular causes. Abdominal ultrasound assesses liver size, echo texture, and biliary dilation. Doppler studies evaluate hepatic and portal vein flow. It's crucial in Budd-Chiari syndrome. The CT or MRI of the brain is done if there is altered mental status or signs of cerebral edema or to exclude other causes of encephalopathy. In selected cases, a transjugular liver biopsy may be necessary to diagnose conditions like autoimmune hepatitis or Wilson's disease. Prognostication and severity assessment. The King's College criteria helps determine the need for liver transplantation. In paracetamol-induced acute liver failure, transplantation is indicated if the arterial pH is less than 7.3 or all three of the following are present: INRO greater than 6.5, creatinine greater than 3.4 milligrams per deciliters, and grade 3 or 4 hepatic encephalopathy. In non-paracetamol acute liver failure, transplantation is indicated if the INRO is greater than 6.5, regardless of the grade of encephalopathy, or if 3 or more of the following are present: age less than 10 or greater than 40, time from jaundice to encephalopathy exceeds 7 days, INRO greater than 3.5, serum bilirubin over 7.5 milligrams per deciliters, and drug-induced acute liver failure, or factor V level is under 15% with grade 3 or 4 encephalopathy. Management of acute hepatic failure. Management of acute hepatic failure requires immediate ICU or high dependency unit admission. Airway protection is crucial. Intubate if patient is in grade 3 or 4 encephalopathy. Position the patient in a 20 to 30 degrees head-up tilt to reduce cerebral edema. Monitor vital signs continuously: respiratory rates, heart rate, blood pressure, temperature, and oxygen saturation. Conduct regular neurologic assessments. Monitor Glasgow Coma Scale and pupil reactions hourly in advanced encephalopathy. Insert a nasogastric tube to prevent aspiration and to clear gastrointestinal blood. Further supportive care include inserting a urinary catheter and central venous line to monitor fluid status and renal perfusion. Correct hypoglycemia and electrolyte disturbances. Other daily lab tests: full blood count, electrolyte urea, creatinine, liver function tests, INRO, and glucose. Avoid sedative unless the patient is intubated. Initiate nutritional support. Enteral feeding is preferred. Protein restriction is only advised if encephalopathy worsens. Start proton pump inhibitor prophylaxis to prevent stress ulcers. Treat suspected infections empirically, especially in the presence of fever, leukocytosis, or hypotension. Correct coagulopathy judiciously. Fresh frozen plasma or platelets should be used only if the patient is actively bleeding or before an invasive procedure. Most importantly, refer the patient early to a liver transplant center. Time is of the essence. Let us take a look at some of the specific therapy. Etiology specific treatment improves outcome in acute liver failure. In paracetamol overdose or toxicity, administer N-acetylcysteine immediately. N-acetylcysteine may also benefit patients with non-paracetamol acute liver failure. For viral hepatitis, for hepatitis B virus, initiate antiviral therapy like tenofovir. Hepatitis A and E are managed with supportive therapy. Autoimmune hepatitis responds to corticosteroids. In Wilson's disease, chelation therapy with penicillamine is indicated. Mushroom poisoning is treated with silibinin or N-acetylcysteine and activated charcoal. For encephalopathy, admit to intensive care units. Use oral or rectal lactulose. Lactitol is also an alternative. They help to reduce ammonia. Rifaximin may be added to suppress ammonia-producing gut flora. Elevate the head of the bed and monitor for signs of brain herniation. In cerebral edema, use intravenous mannitol, hypertonic saline, and possibly mechanical ventilation if needed. Seizures should be managed with phenytoin. In coagulopathy, administer fresh frozen plasma if the patient is bleeding. Vitamin K can be tried, though it's often ineffective in acute liver failure. Platelet transfusion is considered if the platelet count drops below 50,000 per microliter. Infection control is crucial. Common organisms include gram-negative bacteria and fungal organisms. Prophylactic antibiotics are controversial, but treat infections early. Use culture-guided antibiotics when possible. For renal failure, especially hepatorenal syndrome or acute tubular necrosis, maintain adequate intravascular volume. Avoid nephrotoxic agents. In hepatorenal syndrome, administer telepressin with albumin. Initiate dialysis if indicated. Management of ascites. Manage ascites with fluid restriction, low sodium diet, and diuretic. Hypoglycemia is corrected with intravenous 50% dextrose. Address electrolyte imbalances such as hypokalemia, hyponatremia. The extracorporeal liver support system, otherwise known as liver dialysis, provides temporary liver support while awaiting recovery or transplant. This system assists detoxification and maintaining metabolic balance. Examples include the molecular adsorbent recirculating system, the MAS, the Prometheus system, and the single pass albumin dialysis, the SPAD. These are bridge therapies, not definitive treatments. Liver transplantation. Liver transplantation is the definitive treatment for eligible acute liver failure patients. Indications include the fulfillment of King's College criteria we discussed previously. Early referral and transfer are vital, ideally before the King's College criteria are met. Absolute contraindications include uncontrolled active infections, irreversible brain damage, established multi-organ failure. It's important to note that timely access to transplant significantly improves survival. The prognosis of acute liver failure depends on etiology and timely intervention. For paracetamol-induced acute liver failure, they have a relatively better outlook. 60 to 70% survive without transplantation. For non-paracetamol acute liver failure, they carry a poorer prognosis. 30 to 40% survive without transplant. However, with transplantation, survival improves to 60 to 80% at 1 year. Factors influencing outcome include the cause of the acute liver failure, the grade of encephalopathy, and access to intensive and transplant care. Preventive measures include the rational use and prescription of hepatotoxic drugs, public education in dangers of paracetamol overdose, clear labeling of over-the-counter drugs and supplements, vaccination against hepatitis A and B, ensuring safe blood transfusion practices, avoiding unregulated HEPA medications, and promoting harm reduction in substance users. Let's take a look at this case discussion. A 32-year-old woman presents with a 5-day history of jaundice and confusion. Lab shows elevated AST and ALT, INRO of 4.2, and ammonia of 98 micromoles per liter. Viral hepatitis panel is negative. She reports recent herbal medication use. What is the diagnosis? What is the likely cause? Outline the management of this case. Kindly provide the responses to these questions in the comments. To summarize, acute liver failure is a true medical emergency with a high risk of mortality. Early diagnosis and referral to a transplant center are crucial. Identifying the underlying cause enables targeted therapy. Supportive care stabilizes the patient and prevents complications. Prognostic tools like the King College criteria helps to guide transplant decisions. Multidisciplinary management involving intensivists, hepatologists, and transplant teams ensures optimal outcome. Having discussed acute liver failure, let us revisit our quiz questions. Question 1. A patient with acute liver failure, INRO of 7.2, grade 3 encephalopathy, and creatinine of 3.8 milligrams per dl. What is the next step of management? Simple. Urgent referral to a liver transplantation. If you look at it properly, this patient is meeting the King's College criteria. Question 2. Which condition is most associated with hyperacute liver failure? Wilson's disease, hepatitis C, and Buchiari. The answer is B, acetaminophen toxicity. What is the most common cause of acute liver failure in developing countries? The answer is viral hepatitis. Thank you for your attention. I hope this presentation has deepened your understanding of acute liver failure. Stay updated and stay vigilant. Keep learning and stay sharp. If you found this helpful, don't forget to subscribe to our channel, like the video, and turn on the notification bell so you never miss out on more high-impact clinical content. Share this video with your colleagues and fellow learners. This is ClinMed Compass, your path to medical excellence.